Hello, and thanks for joining you. I'm Dr. Tara Scott. I'm the director of Forum Health Akron, and we are so excited today to talk about fertility with Dr. Kasey Marelić. So I am an OBGYN by trade and also a recovering IVF patient. So I have a special feeling in my heart for infertility. So I'm so excited to collaborate with Kindbody on this webinar. And so we were just recently introduced at the opening of a Columbus office. So Dr. Marelić, why don't you introduce yourself?
Hi, and thanks so much for having me. My name is Kasey Marelić. I am the physician at Kindbody Columbus in Ohio, and we are a part of a larger network of clinics all across the country. I'm also the medical director here, and yeah, really excited to partner with Forum and talk about fertility and how we can be a part of women's healthcare.
Great. So can you briefly explain the services that Kindbody offers to patients who are looking for fertility treatments, such as egg freezing and IVF?
Sure. One of the great things about Kindbody is the spectrum of care that we provide. And it's one of the things that really attracted me to Kindbody in the first place. So one of the great things about, I think, women's healthcare now is women are so much better informed, right? So they are playing more of a role in their own healthcare and they are more proactive in screening and decisions. So that's one of the beautiful things about Kindbody is we provide that full spectrum. So I see a lot of patients who actually aren't even interested in fertility treatment yet. They just want to learn about their own fertility. What does my egg supply look like? Are there any red flags I need to worry about in the next year, 5 years, 10 years down the road when I am ready to start a family? So Kindbody provides something called a pulse assessment, which a lot of patients take advantage of, where we just provide basic fertility screening without any treatment. But then if patients come to see us for fertility treatment, if they've been struggling to have a family, if they've been referred to us by a physician for a specific issue, we can basically address and treat any issue that patient presents for. So, that ranges from a couple trying to conceive to, patients who need donor sperm, donor egg, surrogates, gestational carriers, and patients who want to preserve fertility through egg and embryo freezing, sperm cryopreservation, basically anything a patient would need, we can provide, which is amazing to be able to have all those tools for patients. And I'm curious, Dr. Scott, can you describe your approach to women's health and preconception with a functional health approach at Forum Health? Because again, I think for me, I see a lot of patients who are in that preconception phase. They want to have a family in the future, but they're interested in health screening. And then also patients who are having fertility issues and they don't just want a Band-Aid, right? They want to be able to address the underlying issues. So I was hoping to get a little more information about what you can provide for our patients as well.
Right. And so I agree with you that a lot of people are so much more proactive about things. I used to see women mostly in their 40s, but I'm seeing so many teens and 20s and 30s now. Not directly preconception, but just kind of making sure everything's okay. And so as you know, as an OBGYN, if you present to your doctor with irregular periods, there's a certain assessment to make sure you don't have a pathological problem. And in the absence of that, you're given birth control pills, right? Whether you're trying to prevent pregnancy or not, that is the Band-Aid that you speak of. So we're seeing so many more people who either don't want to take the birth control pill for whatever reason, or don't want to prevent pregnancy, but don't want to get to that point where they're going to take a medication to stimulate ovulation. So a lot of what we do is hormonal assessment. And so the endometriosis patients, we now have so much more data on the gut microbiome and how that affects endometriosis, on aromatase activity, and what we call SNPs, the genetic SNPs of estrogen detoxification. So we have functional testing that looks at either traditional blood testing. A lot of times we'll do a dried urine test to look at their metabolism of their estrogen detoxification. We do stool testing to look at their microbiome. Of course, we're going to look at insulin resistance in a patient, not just PCOS patients, but patients who are overweight with insulin resistance who are going to impair ovulation. So we do a lot with metabolism. Instead of waiting for them to get diabetes, we're going to talk to them about diet, what they consume. We talk to them a lot about environmental toxins that can be harmful when they do want to get pregnant in pregnancy, as far as environmental detoxification and endocrine disruptors. We do an overhaul on their diet, and some of them do want to know about their genomics as far as in relation to maybe not passing on a genetic mutation for an embryo or a child, but something that would make them have a Hashimoto's thyroiditis or some other thyroid condition where a lot of them are not sick enough to see an endocrinologist and maybe not getting a holistic view of their thyroid. So a lot of our patients at that age are just doing a more extensive blood panel from a standard lab. And then we have our little armamentarium of functional testing as well.
Sure. That's amazing. I mean, this, I'm sure you hear this all the time, but your specific specialty and field of medicine is just fascinating. And there's a lot of tests that are ordered in functional medicine and integrative medicine that I don't even know about, right? And it's one of those things where I think, again, because patients are so well informed now, they are asking these questions like, why isn't this being addressed? Why are we just jumping to this treatment without looking at the underlying issues, right? So you kind of touched on this, but I'm curious. So with specifically a preconception patient, right? Like, so I see a lot of patients that come to me, they walk in the door and they say, my OBGYN says I have PCOS. And she says I need fertility treatment. And, I go through and say, well, how is the PCOS diagnosed? What treatments are you, what supplements, what diet? And the answer invariably is nothing. I was told I have this condition and I was told I need to see you. Or, you mentioned endometriosis. So specifically with these preconception patients before they hit my door, right? How do you address these issues? How do you counsel these patients? And what specifically do you do before they come to me where I do press that button and ideally I'm like, let's do fertility treatment instead of me having to take extra time to address those underlying conditions before starting any kind of fertility treatments?
Yeah, the PCOS patient, again, is probably one of those patients that's offered birth control pills right from the start again. And so, we're going to obviously work very heavily with their diet. And so usually it's a low carb, a modified paleo diet that they do well. Some intermittent fasting has really been shown to decrease fasting insulin really quickly. So we do follow fasting insulin as well as an A1C and a fasting glucose. We don't always do the oral glucose tolerance test, and sometimes we do even continuous glucose monitors. It's just a 2-week trial so they can see, hey, when I eat this, my sugar spikes. And if I pair my salmon with the sweet potato, then it's a little bit better. So food pairings, we have a health coach that works directly with them and can be involved as meal plans or just kind of to be an accountability partner. So we have a great network of health coaching. We have gut detoxes as well that they can do. One's called GDRX. And so if they wanted to kind of do that before pregnancy, the thyroid, the PCOS patient has a high incidence of thyroid conditions too. And I find that a lot of family doctors are just screening with the TSH rather than the thyroid antibodies, the full T3, T4, the free versions. So we're finding a lot of subclinical thyroiditis. And as you know, with a positive thyroid antibodies and a subclinical thyroid, there's an increased risk of miscarriage. So we want to get their thyroid function optimal before seeing you for any kind of aided fertility to maximize their best option. So a lot of it is diet, lifestyle, and in my world, we identify a lot of problems with estrogen detoxification. And that's just as simple, the SNPs of the cytochrome P450, the first phase of estrogen detox or the second phase or the gut even, so a lot of that will get those patients, up and running and cycling. And then if they still need, ovulation induction or if they need sperm, because of a sperm issue, then they can go on. But what are the common things that you're seeing that are misconceptions that patients have about fertility treatments?
There's a ton. I mean, there's a ton. And, again, misinformation is huge for multiple reasons. I mean, we've mentioned multiple times already, patients are so well informed, right? And that can almost be a detriment because there's so much information out there, and there's no filter for patients, right? They can go on Google, they can go on Reddit, they can go wherever they want and basically just get endless information, right? Without having that filter of, yes, there's all this stuff out there and you read this and this and this, but these are kind of the things that actually apply to you, right? So I think one of the biggest misconceptions that I see in patients is that once they walk in the door for fertility treatment, we're going to push them to IVF, right? We're going to be super aggressive. We're going to take out the big guns. We're going to give them all these hormones. They're going to be miserable. It's going to affect their whole life, right? And that's not the case. And specifically, again, one of the wonderful things about Kindbody and why our partnership with Forum is great is we don't do that, right? We really involve the patient in their own care and help them make these decisions with us. And for me, in a perfect world, I'm not just slamming a patient with hormones. I'm not just giving her medications to make her feel tired and bloated and crampy and like a shell of her former self, right? A lot of the fertility treatments now are really geared at individualizing care, maximizing benefits while minimizing any kind of side effects, right? And part of that is partnering with somebody like you, like Forum Health, who can address these underlying issues to maximize anything that I do, right? If you've got a patient with uncontrolled insulin resistance, anything I do is going to be more difficult, right? So that's a huge misconception, is that fertility treatment is awful, that it's going to change your whole life in a negative way. We really try to minimize that. And a lot of feedback that I hear from patients as they go through this journey is, this wasn't as bad as I thought. Like this was a much, I don't want to be here, right? Because, especially if it's a fertility patient, I'm here because I can't have a family right now on my own. I need to get these issues addressed. But a lot of patients are like, this is not nearly as bad as I read on the internet, or this test that you did on me was not that bad. So I think that's one of the huge things that we see, is just like, the misinformation out there. And then I love seeing that the flip side, when patients are like walking out that door pregnant and saying, this wasn't that bad. So, yeah. Yeah. Um, so, one question for you is, and I think comes back to how well we work together. Um, can you kind of explain how we integrate our care, like my end of the spectrum with the fertility treatments, with your end of the spectrum, which is sort of treating these underlying issues and getting these patients in an optimized place, not just for fertility treatment, but for pregnancy, right? And beyond.
Well, one of the things I loved about the Kindbody approach, as you mentioned, is you guys are more holistic, more in line with our policies and procedures, and you have a whole section on your website about mind body assessment, right? Which I love that, because I think about when I had 13 failed cycles before my IVF, maybe, of various, ovulation induction. And the month of my IVF, my husband's grandmother had ovarian cancer and my dad had surgery for prostate cancer. So I was like, oh, this is the worst possible month. I'm not going to get pregnant. And so I think I wasn't stressed about it. And so I feel like I let down my guard. I'm like, it's probably going to fail anyway. And I conceived. So we know how important that cortisol and that mind body medicine is important. So, handing off a patient that we know that's going to be addressed, that you have dietitians that are going to talk to patients about that, that's going to continue what we've started, is definitely one of the things we love, is because, you've got to continue that. And you and I both know after the baby comes, that's when the stress starts, so So it's not even over. So getting all that, so I loved, that. And so I think that's one of the things is that some of the patients going through their pregnancy journey or even fertility journey still need their thyroid managed, still need, their, if it is an insulin or diet, or if it's something like that, they still will need that alongside of your hormonal manipulation or ovulation induction. So it's good to kind of any burden that we can take over so you can concentrate on, your wheelhouse and not have to worry about a lot of questions about something else. I mean, I think that is really helpful when you have a synergistic effect.
For sure. It's so funny you mentioned the stress piece because that's something that I also really emphasize with my patients because they, and I get it. Because I'm a fertility patient myself too, and I have been in the past. And it's one of those things where you're like, okay, what can I do? I gave up wine. I I cut this out. I cut that out. I don't, I don't watch TV anymore because of the, I don't do any of these things. And, one of the things that I do address with them is don't do that, right? There are lots of things that we know that affect fertility, right? Stress, cortisol is huge. If you have a glass of wine a couple days a week, is that going to affect your fertility? No, but you being stressed out because you can't function and feel like yourself, that's going to raise your cortisol and then you're going to be stressed out. And so I love that you brought that up because it's so huge.
Yeah. So, what does the typical fertility journey look like for a patient that is coming to you? Say we hand off a patient and we're kind of getting their thyroid managed, and then they're ready to kind of step forward because either a low AMH or because, poor ovarian reserve, and we want to maximize their chances.
Sure. Yeah. So, just as in any field, it's really individualized depending on the diagnosis, right? And so that's part of what I love about my field and my role here at Kindbody is I really do involve the patient in the decision making, right? And kind of how I explain it to patients, like I'm not a cardiologist, right? If I'm a cardiologist and I tell you, you need to start this medication or you're going to have a heart attack, right? You're going to start that medication. You don't have an option, right? You don't have a decision really. It's like start this or you're in trouble, right? For fertility care, there are so many options, right? And choosing the right option depends on multiple factors. So, a lot of my patients I see virtually for their initial visit. We 100% accommodate in-person visits. It's just what the patient prefers. Sometimes they want to see me in the office, and when they come in that day, based off the assessment, I can do the full workup, ultrasound, blood work that day. A lot of patients have a busy schedule and they're like, let me just get my foot in the door, let's get my history down. And so we do a virtual visit, just go over the comprehensive patient history, figure out what they've had done prior to coming to see me. And then based off of that, we order a battery of testing, right? Ideally, to your point, patients have seen you or another functional physician first, and they have some of these pieces already identified and addressed. And that's becoming more common, but not as common as we would prefer, obviously. But once we get the results of everything back, I have an extensive conversation with the patient. Like, this is what I think is going on. Now, as you're aware, a lot of patients have unexplained infertility, which is the most frustrating diagnosis because it's like, okay, well, something's going on, otherwise it would be working, right? But once we have the diagnosis, we really work with the patient to put together the treatment plan. And for some patients, that answer is, I just want to do IVF. I want to do what's most aggressive right off the bat. I don't want to do anything else. But a lot of patients are, they're like, I just want to get pregnant. So let's make this happen. And so the great thing that I love about Kindbody and my practice in Columbus in particular is I'm the only physician here. So the patients know me. They all have a direct line of communication. They all have my cell phone, so they can all get a hold of me. And so, yeah, it's usually good. And our office is small, so it's kind of an intimate feel. They know my staff, they know my nurses, they walk in and they just feel comfortable, right? And that's, Our office is meant to feel very comfortable for these patients. We don't want them to feel like they're sick. We don't want them to feel like they're going to a doctor, right? Like, yes, I am a physician, but we want it to feel more, again, you're a partner in your care. And I think that's the experience they have with me and with all Kindbody clinics is I'm here, I'm going to get taken care of, I'm comfortable, I'm confident, and this is going to work for me in the end. So we just, we try to support them throughout the journey and beyond. Again, that's another piece. Like, a question I have for you is about kind of postpartum care, pregnancy, postpartum, during fertility treatments. I'm sort of manning the helm on the fertility side right through that journey. How do you support patients through that whole spectrum, the fertility treatment, the pregnancy care, and then even postpartum?
Oh, that's a great question. And I've heard recently postpartum referred to as the fourth trimester, which I'd never heard that before. So I think, a lot depends on their obstetrician. We often have still managed thyroid dosing and management through pregnancy if the patient wants us to. We'd obviously defer to the OBGYN, once they're in the second and third trimester. But when you have patients who have a hormone abnormality, and especially like a PCOS patient with a insulin resistance issue, like they're still going to have that hormone problem postpartum. And when they are nursing and not cycling, obviously there's not a lot we can give them as far as like hormone support, but there's still things that we can do. So if they still have the insulin resistance postpartum and they have their postpartum GCT and then they still have issues, we can have work with them with that. And I feel like we try to meet the patient where they are, because you can't, a new mom is not going to be able to stick to a rigid, meal plan, and she may not even be making her own meals. People may be bringing it to her. So, but, empowering them to know about food and macros and what's best for her body. Again, as I mentioned, like monitoring thyroid doses, those are going to shift a lot with, blood volume changing during pregnancy and postpartum. And depending on how much inflammation they have and how much stress they have, addressing their cortisol and issues that are going to be sleep deprived. There's very few newborns that sleep right away, and whether they nurse or not. So
Can you fix that part?
I don't have a secret on sleep training. I know. I mean, but I did breastfeed twins, so that is my claim to fame, right? So, I think with us, a lot of what we do is ongoing care. So some of our patients come in for a specific complaint, maybe a gut complaint, and then we heal them and they're on their way. But some of our patients are continued patients as their hormone issues continue, or maybe they have food sensitivities or gut issues, or their microbiome has changed, or they've had a C-section and an operation and antibiotics. So we need to get their gut back into shape. And so, we do a lot of that, and sometimes we won't see them during their pregnancy until after. So we kind of leave it up to the patient as to whatever that, what kind of support they need. And I'm sure, with you seeing them like pretty much active during the first trimester, you kind of notice the same thing, and then maybe they'll, come back and have, a check-in for the next one. But I loved hearing what you said about like all the informed decisions. And so I was, through social media and everything with websites, one of my patients just graduated from college, got hired with a big corporation. And she said, hey, they cover egg freezing. Like that's a benefit that she has on her insurance. And it wouldn't even have occurred to me, a lot of these people are going to these high power careers, and, that would even be a thing. So like, how do you talk with people about informed decisions about their care, whether they want to be proactive? If a patient comes in, I hadn't heard of the pulse check. I love that. And so that's a great place for patients to go and find out where they are in the continuum, instead of waking up at 38 and discovering like, hey, I kind of missed my best window. Because you have who was it that recently got pregnant at 47 in Hollywood? It was somebody, and they never disclose whether it's aided or not. It was somebody that just had a
I know
baby.
Cameron Diaz was in her.
Cameron Diaz, yeah,
Yeah.
Cameron So super, and of course she looked fantastic. And so I think there's more of an awareness. So what does that look like? I mean, how do you
Right.
consent them to talk to them realistically about expectations?
Yeah, so that's a great question. And I mean, the pulse assessments I love because those really do give me the opportunity to give patients empowerment because this is, when patients come to see me for a fertility assessment without any diagnosed issues at that point, that's really, it's an amazing time to give them information, right? Because to your point, a lot of women are postponing childbearing until later in life because of choice, right? Career, education, lots of different reasons. And what I hear often from patients that come to see me is they say, well, my OBGYN said, well, you're 26 and you're healthy, so you don't need to worry about it, right? Or you're 30 and you're healthy, you have regular periods, you don't need to worry about it, right? And so we really try to get the word out through Kindbody, through social media. Hey, be informed. This is your life, your decision. If you have this question in your head of what is my fertility, do I need to worry about this, right? Get it checked out. And as I'm every single patient that walks in and says, I'm just wondering, should I freeze my eggs? I say, yes, 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 yes. There's really, now that there's a lot more, historically, why wouldn't you do it? Well, it costs money, right? With increasing coverage, the answer is always yes for me. So with those patients who come in for a fertility assessment without a diagnosis, I really do just try to give them all the tools. At the end of the day, I'm like, if you were even thinking about this, yes, but here's what I think about your fertility long term. The harder piece is counseling and empowering and educating patients who do come in with a fertility diagnosis who are struggling to conceive, because a lot of patients that I see are already discouraged, right? Usually I see a patient after they've already been trying over a year to try to get pregnant. They maybe have tried treatment with their OBGYN, which has failed, and then they come to see me and they're discouraged, right? They're not in a great place. They're upset. They feel like there's something wrong. They feel like this is never going to happen, right? And again, part of what I love about my job is trying to help them. I see patients who have had partial workups, misdiagnoses, and being able to counsel these patients and say, this is what this looks like. You're going to be okay, right? So let's talk about these decisions. Let's talk about, what tools you have to achieve this goal that you want, right? There's, we already mentioned this, there's so much information and misinformation out there. I think, and your website, I love Forum's website. It's amazing. There's so much patient-centered information on there. It's so patient-friendly. And, I send patients there sometimes for information. Kindbody has a ton of amazing information for patients. And, this isn't the first place I practiced. And, when I came to Kindbody, I was like, oh my gosh, they really understand people. Like they understand people, right? They're not just putting out like, this is the clinical recommendation in, doctor speak and that nobody can really interpret, sometimes even physicians, right? It's, being able to present this information to patients so they understand it. And so they feel like they get it, right? Like, I understand why you're treating me this way, and I understand, what the next steps are. And I think that's another piece that, I know you do really well, is providing that longitudinal journey where like, okay, if this doesn't happen, this is what I think we should do next. So they know what the next steps are, right? They have that whole journey mapped out.
Well,
Um,
just piggyback on that, since you brought up misconception and misdiagnosis, and maybe this is, controversial. I had a patient who was young, in her 20s, and came to me for irregular periods, right? Not single, not interested in fertility because she's still in graduate school and has having irregular, short cycles. And so she went home to where she lived and went to a big reputable medical center, and they ran an AMH, which was very low. And based on that, they gave her the diagnosis of primary ovarian insufficiency. And I was confused because she still has monthly cycles. She has very high levels of estrogen when we check them, very high. And nobody offered her egg freezing, And so I said to her, and I'm not treating her for infertility, obviously. We're trying to get her cycles regulated and hormones regulated because she's just she doesn't, not interested in fertility. But
Right.
I, I like how you said that, because the other thing I see sometimes with patients is, because based on, and again, like I said, maybe correct me if I'm wrong, there's published fertility rates, so they don't want to take on patients with a lower chance of fertility, so they wouldn't even talk to her about IVF when the time came.
Right.
And so, can you just kind of speak to that and Kindbody, like how you handle those types of patients? Because a lot of a lot of big centers, and I love that you said our patients feel, they have that connection with you. You're giving them personalized advice, which is what we try to do. How do you navigate that scenario with a patient,
Right.
and and those rates that are published?
It's tricky, and it's, one of the things that I've learned throughout my career is, there are things that you as a physician, and for me as the medical director of my clinic, have to worry about, right, and be concerned about. And then there are things that, at the end of the day, why are we here, right? We're here to care for patients. We're here to improve people's lives, right? So just to take a step kind of sideways, I think, one of the beautiful things about our partnership is we do see the patient holistically. Like, to your point, I see so many patients that were treated or evaluated somewhere else and given a diagnosis or given a prognosis, and basically because the center was too large, or they were too busy, or this isn't my specific field, or, we don't take on patients like that because they're too difficult, right? The patient is sent away and told, this is your option. You don't have, this is your one option and that's it, right? Or you have no options or something like that. And, um, I find that a lot of centers, not just fertility, but healthcare in general, right? Patients are being fed a tagline because of some other underlying issue, right? So with egg freezing, one of the great things is, that, so all fertility centers, or most fertility centers, publish our rates, our success rates, right? And so it's available to all patients, so they can look at it and say, okay, what's a good fertility clinic for me? What's the best fertility clinic? Because the best fertility clinic is going to have the highest pregnancy rates, right? Now, there's some of the centers with the best rates have that because they screen patients out, right? And it's how they report their data. And so the good thing about Kindbody is we are large nationwide, right? We have a ton of clinics, so we have a ton of numbers, power behind us, but then the individual clinics are smaller, right? So for me, if it's an egg freezer, that's not reported on rates, right? That's not a pregnancy rate. So anybody can freeze eggs. You can have a very low AMH, a very high AMH. I always tell patients, as long as you have eggs, I can work with that, right? If you don't have eggs and you're menopausal, right, different story. But as long as you have eggs, I can work with that. Patients with, these diagnoses of primary ovarian insufficiency or failure, or whatever people are calling them, in the general population, those patients are often mishandled because, to your point, it's not going to be necessarily an easy case, right? But 9 times out of 10, when those patients come to see me, I give them a chance and they have eggs to freeze, right? So, and patients who are difficult cases, right? Like Kindbody, we offer all patients a chance, right? So I see a lot of patients that were basically denied care by another center because their AMH was too low, or they were too old, or, lots of different reasons. And I go through their history and I say, well, did they try this? Did they try this? Did they try this? Did they try all these different treatments? And the answer is invariably no. They basically told me, based off of my blood work, I'm not a candidate for X, Y, and Z. And to me, that's it's insane, right? And as a patient, to hear that, well, can we just try? Like for me, if and I am a patient, right? And I have been that patient, and saying, can we just try? Can we at least just try? So for me, and this in medicine, it's all about risk benefit ratio, right? if I think you have a chance, or if I think I can do something that somebody else hasn't offered to you, and the risk is minimal, right? And the benefit may be huge, we try it, right? And again, that comes back to that partnership with that patient, involving them in that discussion. Like in some patients, I do say, this is a long shot, but we can try it.
Yeah, that's
Right.
a great message for patients because, like I said, I mean, I've had patients that have flat out been told, we're not going to do that. You have to get a donor egg, or we won't try. And you think about,
Ultimately, they might, ultimately they
yeah,
might,
they
right?
might, but they might want that chance. And that's why we use, we say N of one, which meaning we're just going to talk to you is what's best for you. It may not work. You still may end up, like you said, doing this, but at least you can have peace saying, hey, I tried it. I did the
Yeah,
stimulation. I did or didn't get eggs, or and especially like you're right when you're talking about egg freezing. That's a good point. I mean,
yeah,
that's not, it's pregnancy rate for IVF, not necessarily egg freezing. So
right.
those patients should be
Yeah.
encouraged to do that,
At least
especially
they have a chance,
age on the side, they're in their 20s, which is what I
right?
told her. So hopefully, she'll think about that.
Yeah, yeah.
Yeah.
Well, I want to hear, I love success stories, right? So I want to hear from you, something about a patient that, without your help, right, without your care, either they came to you misdiagnosed, or something, and you were able to just improve their quality of life. Can you think of anybody? I know it's on the spot, but
Yeah, the biggest things, a couple subset of people is like these insulin resistance metabolic syndrome patients that aren't given very much guidance. So we have a lot of success with them, not just
Mhm.
losing weight, but getting normal cycles, feeling better. And we've had patients also conceive that have wanted to be pregnant, because clearly when they're not ovulating because they're insulin resistance, then they get ovulating, and they've been successful. And a lot of the patients that we see also could be in that perimenopause, or maybe they're done with fertility, but they're feeling awful. They're not sleeping. They're not just hot flashes. It's not even the most common symptom, but in that perimenopause when they're estrogen dominant, and just by giving them possibly some micronized progesterone, their cycles are more tolerable. They don't want to stab their husbands in their sleep anymore, and so they're more productive at work. The brain fog is better. So that's kind
Yeah,
of either end of the spectrum. But a lot of times, it's a matter of just the approach that you've talked about is like, what are the risks and benefits? Is this going to harm you? And I even talk about what's the return on your investment. This is a generic FDA approved bioidentical hormone. Do you want to take this and look at the payoff? So, I mean, that's been really great, and I think that for patients, our patients, especially in the hormone space, and again, as an OBGYN traditionally trained, we get no training in hormone issues. You have your REI rotations, but on menopause and perimenopause, zero training. So it's kind of
nothing.
fend for yourself. And that's how I fell into it, because after my infertility journey, I still had the same hormonal balance, right? That I had before I conceived kids. And so then I was searching for treatments, and found, the kind of medicine that I practice today. And
Yeah,
so that's been so rewarding when patients have been to several providers, and not found relief of symptoms, resolution of symptoms, and really have not felt heard. And
yeah,
so that's one of the reasons I love that approach in our clinics too, is to try to meet that patient where they are in the journey. I'm not going to say, okay, you all have to run 10 miles a week or do this or that, whatever's going to work for you. So those are
yeah.
the success stories that we hear, and I'm sure I'd love to hear some of the success stories from your clinic as well.
Yeah, sure. Yeah, and I love that. I mean, you're so right. Like, when we get trained as OBGYNs, right? It's like your field and my field. We get so it's the hormones and the fertility. It's like a short rotation, and it's such a huge part of life. And it's amazing that there's practices like yours that are specifically geared to addressing these issues that for the longest time have just been pushed under the rug, right? So yeah, I mean, I love success stories are great in my field. And it's funny because I talk to a lot of my colleagues and they're like, it must be really hard to be a reproductive endocrinologist in REI, right? Because your patients are just, and I'm like, there's lows, of course, right? But the highs are amazing. Like we get to help people get pregnant and have a family, and you know, we have a good number of patients that are, just kind of typical success stories, right? They walk in the door, we find what's wrong, we correct that, they get pregnant, and then they go have their baby and their family, and then they come to you for all the post care, right? But the ones that stick out, right, are the more complex ones, right? The ones that you're like, I helped make this happen. Like this is huge. And to your point, it's those patients that I have had a patient with severe diminished ovarian reserve, incredibly low AMH, still had relatively regular cycles, but was denied care by several other fertility centers. And I told her at the same conversation, I said, we can try. We can try. And she said, I read on the internet, I know this can work. I read success stories about other patients. And I said, we can try. And, I said, just trust me, right? Trust me. I'll get you through this and we'll get you a baby one way or another, right? And she ended up we did a cycle of IVF, canceled because of no response. We tweaked a couple different things, added some different hormones in, and she ended up getting to egg retrieval. We only got 2 eggs, but she was young, right? So the quality was there, and she ended up getting pregnant. And I think her kid had to have been 2 years by now. So it for sure happens. And this is a patient that was refused by other fertility clinics, right? And then even the basics, and this is what's so beautiful about Forum is, this is a patient that you probably would have fixed, right? Or corrected these issues. It was a patient that had been seen elsewhere, told she had PCOS, she had irregular cycles, nobody checked her thyroid, nobody checked her prolactin. Easy one for us, right? One like 101. Nobody checked thyroid antibodies. So she had just very obvious hormone imbalance. Her TSH was way out of whack. She had positive antibodies. Her prolactin was elevated. So you could call it fertility treatment, but I didn't even do any typical fertility medication. We just corrected those hormone imbalances and she got pregnant like basically immediately, right?
That's
And so
amazing.
those I love, where it's like we just have to, work together and make sure these patients are in a good place. And then, a lot of times they get pregnant spontaneously, but if they don't, they're in a much better place to prepare their body for fertility treatments, right?
Kind of along that vein, so piggybacking on that type of patient. So, like, if you have a patient, and now again, as much you probably know the literature more than I do, the utility of that AMH is for a patient currently undergoing infertility treatment, right?
Right.
And to judge the response to stimulation. It's not
Yeah.
really for ovarian reserve, and that's what I explain to patients. But it's being ordered, and so what do
Yeah.
you do with those patients
Yeah.
that don't have that diagnosis of premature ovarian failure or primary ovarian insufficiency that are cycling but have these low AMHs and are not quite ready to pursue fertility? Is that something that you would come up with on a pulse check, or like maybe would that be a referral that we should be sending to you even if they're not kind of in the life stage that it's ready for fertility?
Yes, I love that question, right? And it's so kind of a couple things off of that. So to start with, and you mentioned this, AMH it's a test, it's a blood test, and I have patients that understandably obsess over it, and if it goes up by a point or goes down by a point, and I'm like, this is a blood test, right? It's one of the tools we have, and it helps me dose your medications and it helps me put together your treatment plan, right? But more important to me is, what do your ovaries look like? What does your pelvis look like? What do your hormones look like? Are you cycling? All these other things that go along with it, and again, I've had patients with an AMH that was 0.01 that ended up getting 7 eggs at IVF. I mean, and it's just a blood test. And when it originally came out, it was super sexy, and we thought it was going to be this end all be all of fertility screening and testing and diagnosis. And it's a blood test, right? And so with the pulse assessments and with patients kind of going to their OBGYNs and getting fertility checks, right? You have to take it with a grain of salt. Because to your point, a low AMH doesn't mean infertility, right? Patients walk around all the time with a low AMH and get pregnant, and there's no issues, right? But it is, to me, it's sort of a beacon where if you are younger or, depending on your life stage, and you're not actively looking to get pregnant, but a family down the road is important to you, that AMH can be a beacon to say, okay, maybe I should freeze eggs. Maybe I should, not get pregnant sooner than I want to, but maybe I need to look into these other options of fertility preservation. Maybe there's an underlying health issue that we need to correct. Let's look at all these other factors. Is there family history we need to worry about, right? Did my mom go through menopause when she was 35 or 33, or, so there's a lot of other things that we have to look into if that patient not looking to actively conceive has, concerning fertility testing, meaning a low AMH. When I have those patients, I have that exact conversation with them. It's like, okay, well, you may be fine. You may be totally fine, and you may not have any fertility issues at all, but this is something that may increase your likelihood to consider at least preserving fertility, so that if you do have issues in the future and this number does continue to go down, it's something that you can be more reassured that it won't be an issue if you've done that. So
Let's just
yeah.
say that patient comes to you and decides to do egg freezing at 25 for whatever reason.
Mm-hmm.
And then they're ready to then they have a partner and are ready to have a transfer at 35.
Mm-hmm.
So because they have the eggs already frozen, what is their success? What do you see? And I know without a specific percentage, what do you see the success rate is for somebody who's using 25-year-old eggs, who already
Right.
has the eggs, and you're eating the transfer now,
Right.
transfer and conception, because now they have a partner. So can you comment on success? And because maybe that should be a good point that we should get out there today, is that
Right.
there is this opportunity for patients who are struggling in their 20s. And so what would you
Right.
say that changes success rate?
Sure. Yeah. That's a huge misconception that patients have is, I'll have patients that are freezing eggs and they're like, okay, when do I need to use these by, right? When do I have to use these within 5 years? And everything is about the egg, right? It's the age of the egg that affects pregnancy rates. So that's the beautiful thing about egg freezing and patient empowerment in women's healthcare is if you freeze your eggs at 22, 25, 27, that's your pregnancy rate, right? Pending other huge medical issues down the road and as long as the uterus is normal, doesn't have like fibroids, which we can also address, right? It's the age of the egg that matters. So if you freeze eggs at 25, very high pregnancy rates, and that pregnancy rate stays exactly the same, whether you're 30, 35, 40. Now, there are upper limits where we recommend women don't get pregnant just because of health, comorbidities like 50, 55, we really counsel against it. But even at 55, right? Not saying that it's a great idea to get pregnant, but the rates are the same because it's the age of the egg that affects those pregnancy rates. And that's what's so important because, and that's, like I said, that's my tagline with patients. They'll come in at 32 and say, I just want to get my fertility checked because I think, I'm thinking about egg freezing, but I want to know if I should do it now or in the next 5 years. And I'm like, now, because
Sounds like sooner is always better.
sooner is better. But I try not to be alarmist, right? I'm sure you do this too. I don't ever want patients to feel pressured or pushed in one direction or another. But again, the answer is always yes. Like the answer is always yes. Just do it and do it today. Because again, it locks in those pregnancy rates at those very, very high rates because it's with eggs, and this, it's supply and quality, right? And I tell patients, as long as I have one, I can typically get success. So even if your supply is low, but the quality is great, usually we're good. If your supply is high, I've got some patients who are in their mid 40s, but they've got like beautiful ovarian reserve. We know women using their own eggs in their mid 40s, it's a very low pregnancy rate, not zero, but it's very low. But if I have 20 eggs from IVF, we can maybe get a good embryo or two. But if both supply and quality are low, then it's tough. So
What kind of process after egg freezing do you do to screen do you screen the eggs, or do you have to wait till they're embryos to screen them?
great question. Yes. So yes, to that is the answer. So eggs, it's a single cell. So patients always ask, like, can we screen for my egg quality? What does my egg quality look like? And there really is no test for egg quality, unfortunately. I wish there were. We kind of assume it based off of age, health factors, and things like that. But the egg is a single cell, so we can't test it, right? When a patient goes through IVF to freeze eggs, we give hormones to get as many eggs from just that month. So, and this is also another misconception, and I know you know this, but for patients listening to this webinar, so women recruit eggs every month, right? We're born with all of our eggs, and each month, whether we're on birth control pills, pregnant, whatever, we recruit these waves of eggs. And if you're ovulating, you ovulate one egg, and then the rest die. And that you and I are losing eggs right now, right? We're sitting here
I don't
losing.
think I have any more eggs, actually.
Well, I'm losing eggs right now. It's terrifying. So they just die. They're just, my eggs are sitting here dying right now as I'm giving this webinar. But patients always say, oh my gosh, with IVF, if I freeze eggs, are you taking eggs? Am I going to go through menopause earlier because you're taking eggs? No, it's all we're doing is giving enough hormone to support all of those eggs that you would have otherwise lost that month, right? And so let's say out of a cycle of egg freezing, we get 15 eggs. So not all of those are going to be mature, usually, and fertilizable. So we go through and we freeze the good quality eggs, meaning they're mature and able to be freezed or frozen, but we can't necessarily assess the quality. And so that's, if you ask me what the downside of egg freezing is versus embryo freezing, right? An embryo, you do know the quality and you can genetically test it. And there's lots of other things you can do. But again, if you're 25, early 30s, we're assuming that the egg quality is good because of the age of the patient.
That's a really good point that you made about the IVF and later, because I often wondered, so, I had 15 eggs for my IVF, and I had IVF at like 30. I was young. I wasn't that old.
Yeah.
I wasn't advanced maternal age. And so I often wondered, like, would I go through menopause early? And I'm 55 and still not menopausal technically.
Right.
So it's so interesting, that I'm glad to hear your expertise on that, to tell patients that. But I do see infertility patients have earlier perimenopausal issues, and at perimenopause we have about 3,000 eggs. So I've read fewer than 500 in a lifetime are lost to ovulation. So that would make that not even be a dent, those 15 eggs. So it's an interesting concept. But I do see a lot of infertility patients in the perimenopause space, usually with progesterone deficiencies and things like that.
Yeah. Well, that speaks to, this diagnosis of unexplained infertility, right? It's not unexplained. There's something going on. And a lot of women who have fertility issues, there are underlying hormonal issues that may be contributing, and, male factor as well. There could be male for, that, and kind of how I explain to patients is, I know there's something, right? It's not coming up on clear testing, and what I need to use to treat you sometimes just fixes the problem, right? But then after we get you pregnant, after you deliver, these are things that you should have addressed long term. And I think that's another piece that's missing from a lot of fertility care is we get them pregnant and then they go, right? And then, but I think these patients really benefit from being plugged in with more broad spectrum health care, not just in the immediate, okay, I got you pregnant, yay, good luck, but afterward, during the pregnancy and afterwards, right? And that's why I love this partnership.
That raised another great question. We're actually seeing many more men with hypogonadism and low testosterone a lot earlier. So would there be any benefit, and do you do this? Because, we can't give them testosterone if they want future fertility. So what about making sperm? Do you do that? Do you do any kind of fertility assessment of males prior to, maybe they want to do testosterone or their benefit, but maybe this is a stupid question.
Yeah, no, it's not at all. No, that's great. And I don't see that very frequently, because most of the patients that get shuttled to me are women who find us on social media, friend recommendation, that want to preserve fertility, right? Or through their OBGYN. I see very few men, and that's another cool thing about Kindbody is we offer male consultations as well. So there's a part of Kindbody, it's called Kind Man, and basically we are partnered with urologists who, I'm sort of the entrant, right? So I see that male patient, whether he's partnered or not. I see a lot of male patients that are like, you know what, I think something's wrong. And I don't know who to go to. Do I go to my primary care? Do I go, and so I'll take their history. I go over everything with them. And then if there's any abnormalities, we partner with urologists who address those specific issues. But then, yes, I mean, so, for guys who, and that's another part of fertility care that we provide, guys who do need to be on testosterone, who, diagnosis of testicular cancer, right?
Mhm.
You know, they just freeze a specimen of sperm. And it's, for men, it's not easy, right? Nothing's easy in medicine, but women to preserve fertility have to go through IVF and stimulate and have the eggs retrieved surgically. For men, they just provide us a specimen and we can freeze it, right? The same day. So it's one of those things where if a guy does need to undergo any kind of medical care that would affect his sperm count, testosterone, chemotherapy, radiation, lots of different medications, as you know, affect sperm count. Then he can always freeze a specimen beforehand and then if he needs it down the road, he can use the frozen specimen. Now, frozen specimens, typically they would need to undergo insemination for that with a female partner, but yeah. So I don't see those consults as much, but it's definitely an option.
Is one specimen generally enough? Like, say a man, because I'm just even thinking of someone, we
Yeah.
recently saw his 30s, so like we want to be proactive about this. So, would one specimen be sufficient, or would you recommend a couple specimens?
Yeah. So, and again, and not to minimize the stress of preserving fertility in men, but it is relatively easy compared to a woman going through fertility preservation. So my answer is always, let's get a couple specimens just to have them frozen because one, typically a one collection may be enough, and we can often split that into several vials, so you can use that for a few different inseminations. But it's easy enough to collect the specimen, so the more the better is always my tagline. So one can be sufficient, especially, but then, you never know if your partner or, whatever situation you end up in, if that person might have fertility issues. So you may need multiple vials for multiple attempts. So the answer is always yes, more is better. Can be sufficient, but more is better.
Yeah, well, this has been an amazing, talk, and I've learned so much. Even as I'm not in the guise of fertility anymore, so it's so great to know what's new out there. And it sounds like you're stressing all the same things we are. Holistic health, prevention, being proactive, individualized, personalized care, which is amazing. Now, are there any other takeaway points you think that anybody should know who's watching this webinar?
Yeah, I think we've kind of touched on so much. I think both of us really love involving our patients in their care and their decisions. And and I'm glad medicine is moving towards a place where we are looking at that patient holistically, right? Because sure, you can put this huge Band-Aid on something, but it may fix it, but you may be way more effective if you address the underlying issues. And then again, to your point, long term, there's so many things that we can treat. And I think physicians for a long time have been operating in a vacuum, right? Like, this is my specialty and this is your specialty, and I will do my thing and then I will give you my patient and now you take care of the patient, right? But I think a lot of us are moving towards this partnership where I'm like, you know what? This is my area. You're way better at this than I am, this field of medicine. So let's work together to provide the best care for this patient. I think that's a great takeaway for patients is when you're looking for a provider, when you're looking for healthcare, because a lot of patients do have that autonomy now to choose, right? I can choose where I go. I don't have to go to where my doctor referred me. I can choose. They can look out there and say, where is going to look at me as a person, and what center is going to provide that holistic care that addresses me as that whole, right? And I think that's so empowering for patients to know that there are partnerships like ours and others nationwide that really don't just put band-aids on things, but really address the whole patient. And I think it's amazing. So
Yeah, well, thanks again for your time and for anyone listening. So check out both of our websites, Forum Health Akron and also Kindbody. Do we designate Columbus then, or do you have a separate website?
yeah, so it's super easy to schedule with us too. So kindbody.com is our company-wide website, and you can look by specific site. And we have sites all across the country. We're the big presence in the Midwest in Columbus, but there's also offices in Chicago. And you can look my name up. I'm the provider in Columbus, and there's lots of resources on there for patients as well. And you can self-schedule with us a new patient appointment. Super easy. So.
That's amazing. That's amazing. Thanks again for your time.
You too. Good talking to you. I'll talk soon, okay?
Hi, Dr. Saxena here, Chief Medical Officer at Forum Health. Thanks for visiting our channel. Make sure to subscribe to get the latest insights and information on functional and integrative medicine.